Hotbed Talk.
This piece is in two parts. This is part two. Part one is called Monitoring and Management of Neuromuscular Blockade, and you can find the link in the show notes. This piece is presented by Sol Aronson, tenured professor at Duke University, and Glenn Murphy, Jeffrey S. Fender Chair of Anesthesiology Research and Education and Director of Cardiac Anesthesia and Clinical Research at North Shore University Health System, a hospital affiliated with the University of Chicago Pritzker School of Medicine. It follows on from the talk that Glenn Murphy has given called Monitoring and Management of Neuromuscular Blockade, and it features multiple questions from the audience.
Welcome back. Glenn, terrific lecture. I just love the way that you take a complex subject and just, bring it down to a very easily understood and clear manner by succinctly organizing, if you will, the evidence that exists and regurgitating that in a very logical, sensical way. So thank you. And I see that we're beginning to get some questions on the Slido board right now. Glenn, one of the things that I couldn't help but think about, and I have many questions, but I'm going to sort of get right to the core of what is a practical application is some of the evidence that you shared with us. Given the fact that our methods of monitoring residual neuromuscular blockade are often inadequate, depending on the tools that we use, and that patients often have this sort of subtle hypoxic, if you will, residual. Do you transport and do you recommend routine transport of patients from the OR to the PACU with oxygen?
Absolutely. In the one study I quoted about using monitoring to reduce the risk of residual block in associated respiratory symptoms, we transported patients from the operating room to the recovery room without oxygen. As part of the study design, that's what we did. And you can see the incidence of severe hypoxemic events was 21% in the patients who were transported without oxygen. I couldn't do that study again now in our department. But I think that clearly demonstrates, I think that's a very risky period from the time the endotracheal tube comes out and to the time they're stabilized in recovery room. Again, they don't have their pharyngeal reflexes back. I think that's a period where they may potentially have risks for aspiration, airway obstruction. Look at the studies. When you look at the percentage of patients who have residual block at the time of tracheal extubation, it's anywhere from 60 to 80%. I think really that's a period we have to be very careful. So I would strongly recommend, given the incidence of residual block, that we transport our patients always with oxygen.
Should that be a standard of care? Should we be tolerant of any institutions that don't practice that way?
I think given the data from our study and other studies, I think it should be a standard of care transporting patients with oxygen. Even with relatively minor, what we consider minor procedures, because again, even those procedures are associated with a high risk of residual block. You see studies where they look at major operations and show a high incidence of residual block. But if you look at studies even looking at what we consider minor procedures, there's a high incidence of residual block in those patients too. So I think, given that evidence, I think it really should be a standard of transporting people with that.
It struck me as a really profoundly important observation. How expensive, and I guess on the other hand, how, so far as you know, pervasive is the use of the second generation accelerometer monitors that you spoke to?
As far as utilization, there's no data on that. We really don't know at this time. All of these monitors have recently been approved probably within the last 9 months. So these are all relatively new monitors. I don't know of any data of how much these monitors are being used. As far as cost, typically it seems to be the cost is between $1,500 and $2,000. Now with the accelerometer devices, the advantage is once you buy it, you don't have to buy anything else. You basically can use these monitors until basically the transducers stop functioning. But you do have to have the hand out at the end of the case to use these, which is one of the big disadvantages. With the EMG devices, you have to purchase the strip of electrodes, which cost probably about the same as what you're going to pay for a BIS monitor. So you have to purchase those. My guess is, and again, I'm not sure how their marketing is exactly, but probably going to be you'll get the device for some low cost, but you pay for the electrode strips. It's kind of very similar to what we have with BIS monitoring.
So obviously the physical constraints of using one monitor, the EMG, over the accelerometer monitor because of the positioning and the accessibility of the limb. All things being equal, how would you compare the sensitivity and specificity of those two monitors against each other?
Yeah, Traditionally, EMG monitoring has been shown to be the most accurate. And that's because the mechanomography was the first monitor developed. And that's really the most accurate. But again, those types of monitors have never been developed for clinical care, mostly for research purposes. When they've done studies comparing EMG technology and accelerometer technology to mechanomography, EMG correlates much better. It's much more accurate and reliable technology than accelerometer traditionally is. So EMG is a more accurate technology. And again, the other advantages that I talked about is you can tuck the arm. Since it's measuring electrical activity of the muscle and not movement of the muscle, you can have the arms tightly tucked and basically get train of 4 ratios. With the accelerometer devices, at the end of the case, you have to pull the arm out, put it on, and then look what your train of 4 ratio is. But I would say, again, we should be pulling the arm out in all our patients to look for residual block. One of the big problems, and what I found with our residents, is they're monitoring the eye. And what my residents, so we had 4 strong twitches at the eye. But the problem is you can have 4 strong twitches at the eye and have only 2 twitches at the hand when you're monitoring the ulnar nerve and adductor pollicis. This is important muscle to monitor because this really reflects what's happening with our pharyngeal muscles, our last muscles to recover. So when you're dosing and making decisions on reversal based on what you're seeing at the eye, that may not be accurate. You really need to pull the arm out and see what's going on at the hand muscle to really determine what's the appropriate reversal strategy to use.
And on the other end, to redose the muscle relaxant, I guess you would have the same concerns about sensitivity and specificity by using the, temporal muscle versus the hand, reflection of degree of muscle in relaxation intensity when you make decisions to redose or up the dose.
Yeah, that's exactly right. You have the risk of overdosing when you're using the eye as monitoring. Again, that's probably another advantage of EMG technology. These devices, once you lose your train of 4 ratio, go to a train of 4 count. So with the EMG devices, you can actually get an accurate train of 4 count to help make those decisions about redosing muscle relaxants during the case. So I guess that's another important advantage, I think, of the EMG technology.
Here's a practical scenario I'm sure you've confronted. I know we all have in our lives. How do you manage this scenario when, by all accounts, your monitors, your sensitive monitors, are telling you you're adequately relaxed, and you get complaints or requests from the other end of the screen to increase your dose of relaxation because the patient isn't adequately relaxed?
I think we all have those surgeons at our hospital. We had a thoracic surgeon who every time you work with him would call you to the room, usually was a resident in the room, and say, the patient's moving, the patient's awake, and he would complain nonstop, but you'd put your monitor on and there'd be no twitches. And I think it's in that situation, the diaphragm is extremely difficult to paralyze. You need a post-tetanic count of 0, a post-tetanic count of 0 to actually paralyze the diaphragm. Especially with thoracic surgeons, if the diaphragm's moving even slightly, it interferes with their surgical field. So one of the problems, if you want the diaphragm to not interfere with the surgical procedure, you need a very profound level of block. And again, the level of block that you could only really reverse with Sugammadex. Before, in the pre-Sugammadex era, this was always challenging because he'd want this deep level of blockade, yet he finished up real quickly, put a couple sutures in, put the dressings on, saying, why isn't the patient extubated 3 minutes later? I explained to him, listen, we have to wait till we get 3 or 4 twitches before we reverse with neostigmine. And then the next time I work, we have the same questions again. You get tired of sort of giving the same lecture to the surgeon. But really, that can be a problem. You can have no twitches, particularly if we're monitoring the eye, and a surgeon still be complaining about the patient moving, and it's usually because of the diaphragm.
Good point. I'm going to go ahead and flip over to Slido and see what kind of activity we've had on that board. Oh, looks like we have lots. All right. So first question, as to Gambidex is a unique drug that doses exactly what we want it to do. Why are alternatives still used and available? Wow, that's a real call to action kind of question. Glenn, why don't you take that?
To be quite honest, I couldn't agree more with the question. Not only is Sugammadex more effective at reducing the risk of residual block, it's much quicker, obviously. And now there's data that's been coming out, of which I talked about in the last part of my lecture, where their evidence is outcomes are better if we use Sugammadex. We know residual block is associated with a number of all these bad things. And we know that use of Sugammadex significantly reduces the risk of residual block. And now we have these studies showing Sugammadex reduces risk of things like postoperative pulmonary complications. So why are we using a drug that is oftentimes ineffective? One thing I didn't talk about in this lecture is neostigmine is very slow, and people don't recognize this. If you have 2 twitches at the time of reversal and you give 70 mics per kilo of neostigmine, it's going to take on average 20 to 30 minutes with a range up to 2 hours. Even if you have 4 twitches at the end of the case and you reverse with neostigmine, it takes on average about 15 minutes to work, but again, it can take up to an hour in some patients. And we don't know which patient is which unless we have quantitative monitoring at the time. So it's a slow-acting drug. It's ineffective. Some people it doesn't work at all in. And then we have a drug that's very effective, clean. Its mechanism of action is very clear, and it's been shown to reduce these downstream effects. The only reason we're not using it in everyone, I think, is cost. And I think any anesthesiologist that are given the choice of using neostigmine or Sugammadex would choose Sugammadex. It really just comes down to a cost issue. The most recent data I've heard in the United States is it's used in about 40% of reversals. So in 60% of reversals in the United States, we're still using neostigmine, and the only reason is cost. And I think the people who are making these decisions have to really focus on these downstream effects of residual block. They just basically look at what's a cheaper drug. But you really have to look what's happening downstream to really make an educated decision about, I think, using Sugammadex. But I think, again, I would say we should be using it in everybody.
Next Slido question, please. Some wearables have accelerometer hardware. Are you aware of, or do you know if anyone is studying firm software solutions marshaling this ubiquitous hardware?
I think I think this question is referring to GE has a module, an NMT module, which you can basically plug into the machine, and then it has a technology called kinesiography, which you put on the finger here. That's the most widely used quantitative monitor. And again, in my lecture, I just talked about the standalone monitors, but that's actually available in the GE monitor. If you look at the data in kinesiography and its correlation with mechanomography, which is really the standard, it doesn't correlate very well. But I would say it's much better than using a peripheral nerve stimulator. So it's not as accurate as mechanomography or accelerometer or electromyography, but it's much better than just using a peripheral nerve stimulator. If you have the technology, I think I'd recommend using it. One of the problems is that the software hasn't been updated in a significant period of time. There's talk in the company of basically investing some money to make it easier to use. And as I mentioned, to use these types of monitors, they have to be very simple. You want to just put a monitor on, push a button, and get data. I think the way it's structured now, it's more complicated. It takes more time to use. So I think if they update the software and make it easier to use, more people will use that type of technology.
If one does not use objective monitors or they are not available to you, do you believe neostigmine is reasonable to use?
I think the problem, again, it goes to what I referred to earlier. When you dose neostigmine, the recovery times are incredibly variable. It's kind of like what we see with rock. If we give someone a dose of rocuronium, in some people in 10 minutes it's worn off, in some people 6 hours later it still hasn't worn off. And I think you really appreciate that when you use quantitative monitoring, how variable the recovery times are with rocuronium. And that's one of the reasons I recommend you should always reverse people, because you just don't know how long it's going to take for people to recover. But it's the same thing with neostigmine. Recovery times with neostigmine are hugely variable. So if you, for example, you have 4 twitches at the end of the case and you give 50 mics per kilo of neostigmine, when do you pull an endotracheal tube out? Is it someone who's recovered within 5 minutes, or is it someone who's going to take an hour to recover? And you just don't know. And again, all our standard clinical tests we use, squeeze my hand, hold your head up, none of that is sensitive in detecting residual block. The only way you can detect residual block is with quantitative monitoring. So I would say, in our practice, again, our pharmacies put pressure on us to reduce the use of Sugammadex. I do use neostigmine sometimes without quantitative monitoring, but I think this is an example of why quantitative monitoring is important. So at the end of the case, when you give that neostigmine dose, you can wait until you've recovered to a train to 4 ratio of 0.9 and pull the tube out and be comfortable that they've recovered. But if you don't have quantitative monitoring, you really just don't know how long it's going to take that particular patient to recover.
Would you argue on the other end, if you don't have quantitative monitoring, then all the more reason to use a reliable drug with a reliable pharmacokinetic of effect?
Yes, and again, if you look at the data, if you're using a peripheral nerve stimulator, your risk of residual block with Sugammadex is 1 to 2%. So it still can occur, and there's still some patients who we've all seen, we've given a dose of Sugammadex, it doesn't appear to be working fully effectively. But the risk is very small if you're using a peripheral nerve stimulator. I think I would agree with that statement, that I think if you don't have quantitative monitoring and you want to really optimize safety in your patients, you should be using Sugammadex. I think that, you can get to a train-to-4 ratio of a variety of different ways. I don't want to sound like I'm pushing Sugammadex. Quantitative monitoring is one way you can help your patients recover. Sugammadex is another technique you can use. And even using both of them together can be helpful. At University of Washington, they have a protocol set up where everybody gets quantitative monitoring. And at the end of the case, if they have a train-to-4 ratio less than 0.4, they get Sugammadex. If they have a train-to-4 ratio of 0.4 or greater, they get neostigmine. Because we know if you've recovered to a train-to-4 ratio of 0.4 to 0.6, you can almost everyone will fully recover within 10 minutes if you give an appropriate dose of neostigmine. So there's even strategies of using, I think, both of them together. Of all the ways of managing neuromuscular blockade, that to me is really one of the most scientific and best ways to do it. And they've actually established that to reduce the use of Sugammadex at their institution. And I think it's been effective in doing that.
What's the added value of a post-tetanic, if you will, response in addition to the train-to-4 ratio?
There's a lot of data that's come out of Europe showing that if you maintain deep levels of blockade, a post-tetanic count of 1 to 2, during surgery, that clinical outcomes improve. The patient operative conditions are improved, and they've shown patients may have less pain, particularly shoulder pain after surgery, by maintaining deep block. Now, that's a little bit controversial, but in some of your surgeons who want deeper levels of blockade, having a post-tetanic count, I think, could be helpful.
Sugammadex can only be used to reverse rocuronium, period. Are no other muscle relaxant used in the U.S., for example, atracurium?
Well, actually, Sugammadex is also approved to reverse vecuronium. And if you look at the clinical studies, it works just as effectively. It's just a little bit slower, typically 30 seconds to a minute slower than reversing ROC. So it can also be used to reverse vecuronium. There is some study, I have one single study that showed it worked with pancuronium too. So any sort of steroidal muscle relaxant can be effective. Now, it doesn't work with the benzoylquinones like cisatracurium and atracurium. Structurally, it won't bind to those. So it's very important you recognize if you're using one of those other muscle relaxants, Sugammadex isn't a choice as a reversal agent.
I think this is a standard of normal anesthetic practice in the UK, transferring to the recovery room with oxygen. I'm glad to hear that. Glenn, do you know? I don't think it is a standard of care in the US.
As far as I'm aware, it's not a standard of care that I would get as either.
Yeah. Good for you, UK. Next slide, please. If neostigmine was just coming to market today, would its safety profile or lack thereof deter it?
That's a great question. Would it? Again, this drug was grandfathered in a long time ago. Would it be approved by the FDA? I really have questions whether it would, in the fact that it's slow. You have a drug that's slow acting. It doesn't work in a number of patients. It has a number of side effects, such as nausea and vomiting. If you look at studies comparing nausea and vomiting with Sugammadex versus neostigmine, the risk of nausea and vomiting is significantly higher. Bradycardic risk events are higher with that. Adverse events in the PACU, if you look at these meta-analyses, are significantly higher with neostigmine versus Gambidex. I honestly don't think it would get approved today as a reversal agent.
How prophetic. Is there any difference in the incidence of residual neuromuscular block comparing muscle relaxant given in bolus versus infusion?
I'm not aware of any data that shows that the risk is any different. Again, if you're running an infusion, you'll probably maintain a certain train of 4 count during the obolus. With Bolus, it's going to be basically training for count sort of up and down throughout the case. But I'm not aware of any data that shows the risk is higher or lower with infusions versus boluses. So it's a good question, but I'm not sure of the answer. I know in Europe, it's much more common to run infusions of muscle relaxants. In the United States, it's much more common to give boluses.
Slido, please. Any experience of anaphylactic reaction with Sugammadex in your practice? Or I would expand that to say, please give us your understanding of that reaction in general, Glenn.
That's the issue that held it up from getting approved by the FDA was the concern about these potential anaphylactic reactions. I can say at our institution, we started using Sugammadex the day that it was approved by the FDA because I was very excited to get this into my clinical practice and try it. We have not yet had an anaphylactic reaction to Sugammadex. We haven't seen it. We've used it in tens of thousands of cases. If you look, the best data I've seen on this came out of Japan. Now in Japan, it's interesting that everyone in the country gets Sugammadex. The government approved everybody to get Sugammadex. But also in Japan, they don't have recovery rooms. So patients typically go from the operating room back to the holding area or go back to their room. So they're able to get the drug approved. So it's been used there extensively, more than any other country in the world. And they had a study recently that they looked at the incidence of one particular institution, and it was higher than what's been previously published. It was 1 in 3,500 cases. So that's probably the best data I've seen on the potential risk of it. Again, that's higher than what had been reported in some other risk estimates, somewhere in a range of 1 in 5,000 to 1 in 10,000. So my guess is it's somewhere in that order of between 1 in 3,500 and 1 in 10,000. But we have not seen any anaphylactic reactions from that. I'm curious, Saul, at your institution, have you had any cases of anaphylaxis to Gambidex?
None that I'm aware of, Glenn. So it's a fair question, and I would couch that with I believe that we have not, but I cannot speak to that specifically. With respect to the anaphylactic reaction, what can you tell us about memory in terms of is true IgG or IgG mediated? And what about the patient who had sort of declared themselves as susceptible to an anaphylactic type reaction? Would you go out of your way to avoid this drug on the second or subsequent use or potential need to use it?
That's a great question. As far as the mechanism, it's really unclear. It's not an IgE related reaction. In fact, when they put together some of the allergists to sort of describe to the FDA what the mechanism of this was, they really weren't clear on what the mechanism of this anaphylactic reaction is. Again, in Japan, where they have the most experience with people getting this drug repeatedly. And again, we really don't know if someone's had an anaphylactic reaction to Sugammadex, are they a higher risk of having it again? We just don't have that data. We don't know. And as far as someone who has sort of a risk for anaphylactic reactions, again, the same, we really don't have that data. If you think about what Sugammadex is, a modified cyclodextrin. Cyclodextrins are everywhere in our environment. So there's lots of exposures to cyclodextrins. So, as far as this re-exposure, I'm not sure really if that would be an issue, considering we're constantly exposed to cyclodextrins in the environment.
Next slide, Op. What is the role of Sugammadex in the recovery room?
Yeah, really the data from that comes from a lot of case series and case reports in the literature, where, typically this happens not uncommonly in our recovery room. Someone gets reversed with neostigmine, they get to the recovery room, and they appear obviously weak. What we used to do in that scenario is they call my research people, we run over and put a quantitative monitor on to see whether it was residual block. Now, basically, we just quickly give Sugammadex. And there's no really interactions between neostigmine and Sugammadex, so there's no problem with, if someone's received neostigmine, giving a dose of Sugammadex. So, again, we just have data from case series and stuff. It appears to be safe doing that. Again, we've done that dozens of times in our recovery room, and it's been effective in reversing what we suspected was residual block. Again, in my thought process, when someone's in trouble in recovery room, it's residual block until shown otherwise. One of the early studies we did, we looked at critical respiratory events in the PACU over a 1-year period, and we put on quantitative monitors in all those patients who were having critical respiratory events. 90% of the people who were having critical respiratory events in the PACU had residual block, and 75% of those patients had severe residual block. So, residual block is very common in the PACU. If you suspect it, to me, anytime anyone's getting any respiratory trouble in the PACU, it's residual block and proven otherwise. And I think a simple thing to rule it out is just give them Sugammadex and see if they improve. And we found in a majority of those cases they do better.
So your rescue protocol is Sugammadex before Narcan?
Yes.
What is your opinion about the negative effect of glycopyrolate, cognitive function, bowel function, etc.?
Great question. As far as cognitive function, I believe glycopyrolate does not cross the CNS. So it probably doesn't cause an effect on cognitive function. As far as bowel function, I'm honestly not sure. My guess is it doesn't cause an effect on cognitive function, but possibly on bowel function. The concern that it can actually have effect on the heart, and in particularly repolarization of the heart. And there may be an increased risk of arrhythmias in patients who get glycopyrolate. So we know it has an effect on. We probably doesn't have an effect on cognitive function. I'm not sure about the bowel function.
Are you aware of any studies looking at different doses of Sugammadex? As anecdotal 1 milligram per kilogram dose seems to work very well with train of 4 ratios of greater than 0.9 achieved.
There have actually been quite a few studies published looking at these smaller doses, and they seem to be effective in most of the studies. For example, there's lots of studies in morbid obese patients, because again, we dose on actual body weight, and that's a huge dose oftentimes of Sugammadex. So it's a smaller dose effective. And these studies have shown if you use a dose based on 40% of ideal, based on ideal body weight plus 40%, it's been effective in reversing blockade. Important thing to emphasize in all of these studies is that they're typically small studies. So as far as the ultimate safety, we don't know. Until we really have larger scale studies, I would not recommend using lower doses. And when people looked at doses less than 0.5 milligrams per kilogram, there is a risk of recurarization when you use doses basically smaller than a milligram per kilogram. So I would not recommend at the current time dosing with these smaller doses, because there is potentially a risk of recurarization or weakness in the PACU.
Very good. All right, I'm going to ask one last Slido question, so we'll try to pick a good one from the list. Are quantitative measures necessary if we must always reverse anyway? Are there guidelines for repeat dose if quantitative measurements show inadequate reversal? That's going to be our last question. Glenn, take us home.
Again, as I mentioned in that study, I think quantitative monitoring can sort of guide our reversal strategy. So if we can really decide based on what we find from quantitative monitoring, should we use Sugammadex or should we use neostigmine? Again, if you're using neostigmine as far as repeated dosing, once you've given a dose of 70 mics per kilo, giving any additional neostigmine isn't going to help. You get a ceiling effect with neostigmine. So if you've given a max dose and you still have weakness, giving additional neostigmine won't help. And that's a circumstance where, again, I'd recommend going to Sugammadex to fully recover.
We have many, many, many more questions on Slido. For those of you who asked questions that I didn't get a chance to get to, apologies. Great lecture, obviously stimulating conversation. Again, thank you.
Bye, thank you. Bye-bye.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.